Welcome everybody to this webinar, the SPR webinar by Dr. Bruce Wampold. We're very honored that Dr. Wampold has agreed to give his presentation in this webinar series, especially considering that he's now this year in Valencia in Spain. So he's coming to us from a different location, and we really appreciate his willingness to be part of this series. Dr. Wampold is obviously a very well-known psychotherapy and counseling researcher. I think he doesn't need much introduction. He's a professor in counseling psychology at the University of Wisconsin-Madison, and he's written a large number of research papers, meta-analysis, has won a lot of awards, and is very well known from his book, The Great Psychotherapy Debates, Models, Methods, and Findings. So we're very pleased that he's going to talk to us today about investigating therapist effects. For those of you who haven't attended one of these webinars before, let me give you a brief introduction as to how this works. As you can now see the slides that Dr. Wampold shares with us, and if you have questions, you can type them in the question window, or you can raise your hand. There's an option in your control panel that says raise hand. If you raise your hand, we see that you have a question, and we can open up your microphone. If you do not have a microphone, please add that to your question, because we will always strive first to open up your microphone if you have one, because it's much nicer. Then you can directly interact with Dr. Wampold. Otherwise, we will read your question to Dr. Wampold. So that's the two ways in which you can ask questions. If you have any technical questions or things are not working properly, just type them in the question window, and the organizers will answer you. So my name is Kim de Jong. I will be hosting this webinar together with Julian Rubel, and we are both logged in as organizers, and you will see that as Sven Snyder is talking right now. This webinar will be recorded, and it will be placed on Vimeo, on the SPR Vimeo channel, which you can access on the SPR website under Research Resources. So we usually get a lot of questions, will we get any slides? You don't get the slides, but you can actually review the entire webinar on the website. So that's it for now. Now I'm giving the virtual floor to Dr. Wampold. Go ahead.
Well, Kim, thank you very much for the introduction. Indeed, I'm doing this from Valencia in Spain, missing a winter in Madison, Wisconsin, so life is not too bad. So what I want to do today is talk about therapist effects, both in terms of estimating and discussing what they are, but also to indicate how they really important when we study both outcome and process in psychotherapy. Now, Kim really advised me not to prepare too many slides, that the presenters always overestimate how much material is needed. Well, I've done the same because the topic's so interesting. I probably have too much material, but I will try to stop periodically and ask for questions. And again, as Kim had indicated, you're able to do that either with your microphone or in the chat mode. So let's get started. So research in psychotherapy, we have really two types of research according to many people. Outcome research, in which we study things like, is treatment A superior to no treatment, or comparative designs in which we answer the question, is treatment A superior to treatment B? So that's the primary goal of the outcome research, is to assess the effects of various treatments. Process research, on the other hand, aims to look at what are the important actions in therapy and how are these interactions in therapy related to outcome. And as we'll see in this presentation, I'm going to really talk about how outcome research and process research can be integrated. So some examples of research in outcome. We know that many treatments are superior to no treatment, and that there are some differences, not many, among treatments. So occasionally we find one treatment more effective than another. And the example I'd like to point out here is that interpersonal therapy is found to be superior to cognitive behavioral therapy for severe depression in the NIMH study on depression. We're going to look at that study in some detail during the webinar. In process, probably the best known result is that the alliance, the working alliance, measured early in therapy, is related to the final outcome in therapy. And we'll look at that result as well in this webinar in some detail. So here is a source table that I've made up of a outcome. And in this source table for analysis of variance, we have 2 treatments and 40 subjects per treatment. We're looking just at the outcome measurement. Let's suppose that the patients are randomly assigned to the treatments and the researcher's done everything well here. And we're just simply testing whether one of the treatments is more effective than the other. And you'll see in this source table that the F-test for the test is 6.66, statistically significant, accounts for eta squared, 15%, corrected for attenuation, it would be about 12%. So here we conclude, well, yeah, one of the treatments is more effective than the other. We did a statistical test and it's significant. Well, let's look at that result in a little more detail, because it's not quite that simple. Because in psychotherapy, we have this nesting of therapists within treatments and patients within therapists. So all of the patients are only seen by one of the therapists, quite clearly. And in the typical design, although some designs in outcome research are crossed, although the problems there are quite similar. But in psychotherapy research, we usually have a number of therapists who give treatment A, a number of therapists who give treatment B, and a number of therapists who give treatment C, for instance. Well, if we look at that design, we can see that therapists are an important part of the treatment. So it isn't simply that we're studying treatment A, treatment B, and treatment C, but we're also studying the therapist, in a sense, who are giving the treatments. Well, it's interesting because there's a history of not looking at the providers of service in a number of different areas. So just very briefly, let's discuss those because they're interesting from a historical perspective. So in education, which is interestingly the first place where randomized controlled designs were used in the 1920s and 30s in the United States, the American Psychological Association was trying to prove its usefulness by using the technology that was being developed about research design to education. And the question was, are there some educational programs that are more effective than others? So they'd randomly assign the students to the educational programs, do the test, and so forth. What was ignored in that was the teacher. So it was felt like teachers are replaceable. So in that period, they were usually female. They would teach until they were married and became pregnant, and then they would leave teaching and new teachers would come. So they were replaceable. Teacher doesn't make a difference. What makes a difference is the kind of educational program they're using. The same in agriculture. Sir Ronald Fisher, who developed the analysis of variance that we showed a slide or two ago, was working in an agricultural station and developing statistical methods for looking at primarily seed varieties, irrigation practices, and fertilizers. What was ignored in these designs was the farmer. Does the farmer using those practices make any difference? Now, of course, in medicine, when Western medicine was making a name for itself, the goal was to rule out the effects of the physician. So Franz Anton Mesmer, who practiced animal magnetism, was remarkably effective, but it was due to his charisma and not to the actual animal magnetism. So medicine wanted to ignore as well the provider of the services. It really matters what medicine you get, not who gives it to you. Well, clearly, in each of those instances, we've ignored something important. We know teachers are important, we know farmers are important, and we know the person of the physician is important as well. Well, we've done exactly the same thing in psychotherapy, and in fact, to my knowledge, there's never been a psychotherapy clinical trial in its initial report that focused on therapist effects. There has been some reanalysis of these kinds of data, and we'll talk about some of those in a few minutes. Well, ignoring therapist really assumes that the therapist giving the treatment is unimportant. So therapist effects are not estimated, and the focus is instead on the treatment. There are some methodological differences. The first and most important one is that differences among treatments may not be true differences among the between the efficacy of the treatment, but actually may be due to the therapist. Ignoring therapist's effect increases type 1 error rates, as we'll see, and the effect size for the treatment. And then finally, it confounds the within and between group relationship. And that will be the focus of the second half of the webinar. So the goals of the webinar are, and the investigation of therapist effects is, how important is the provider relative to the treatment? We want to estimate the variability among therapists giving the same treatment. We want to compare therapist variability to treatment variability to determine what's most important in terms of producing outcomes. And we want to understand the characteristics and actions of effective therapists. And finally, we want to discriminate between patient and therapist contributions to outcomes. So let's talk about how to estimate therapist effects. So when we do clinical trials of different treatments, there's various sources of variability. And actually, the same sources of variability are present in naturalistic data as well. But let's think about this in terms of clinical trials for now. So there's treatment differences. In other words, one of the treatments may be truly more effective than another treatment. And that's what's called a fixed effect. It's the difference between the effectiveness of two or more treatments. And we'll denote this by alpha sub j. So j being the Jth treatment. So what's the effect that a person gets by being in a particular treatment, J? But there's also variability due to the therapist. So some therapists may be generally more effective than other therapists. And here, this is a random effect because we want to consider the therapist as drawn from a population of therapists. So when we make a conclusion in a clinical trial, we don't want to just say, well, therapist Bob was more effective than therapist Charlie, but we want to say, how much do therapists in general vary? So we think about therapists then as drawn from a population of therapists, which makes therapist a random effect. And finally, there's error or patient variability. So we try to model the outcomes. Some are due to treatment, some are due to the therapist, but some is variability remains, which is just the variability of patients within therapists, within treatments. So therapist effects is assessed with an intra-class correlation coefficient, which simply is just the amount of variability in the outcomes due to the therapist over the total variability. Or in terms of the equation, rho, the intra-class correlation, is then sigma squared for therapist, the variability due to therapist, over the variability due to therapist plus the remainder, the therapist, or the variability that remains or is the error. So let's look how ignoring therapist results in an increase in the error rate and effect size. So in the analysis of variance, now I should pause for a minute and just say, I'm going to discuss this both in terms of equations but also conceptually as well. So I was trained as a mathematician, so numbers and formulas excite me a lot, but I know that they can be intimidating at times as well. But again, I'll try to do this in a technical fashion for those who are interested in that, but in a conceptual fashion as well. Well, when you look at the expectation of the mean square treatments, there's three components of this. There's a component that's due to the effect of the treatment, and that's the last term, the alpha sub j squared. So that's the term that assesses how much of the mean square treatment is due to actual treatment differences. But you'll notice that this expected mean square also has the middle term, which is the variability due to the therapist. So there's, when we look at the treatment effect in analyses of variance, we also have, as part of that treatment effect, this variability due to the therapist. And of course we have the error as well. So basically what this means is that when you get a mean square for treatment, there's some of that that's due to the actual differences among treatments, but some of that effect is also due to the therapist. So if you think about it, when you, if you could in an experiment randomly assign the therapist to treatments, well, that random assignment is never perfect. In a sense, you might randomly assign the relatively better therapist to one particular treatment than another treatment. So some of the effect you notice is really differences in the therapist rather than differences in the treatment. So that is the treatment effect mean square contains therapist effects. Ignoring therapist effects as a consequence will always inflate the alpha level. In other words, you're more likely to conclude that one treatment is more effective than another treatment than you think you are if you ignore therapist effects. As well, the effect size that's reported in treatment is also inflated by ignoring therapist. So if you think about it, since no initial report of a psychotherapy trial has ever adjusted the treatment effects for due to therapists, every one of those studies has overestimated the effect of the treatments. So here's an example of this. So if you look at the bottom panel, that's the source table that I presented earlier. But here, if we take a intra-class correlation of 0.3, that is 30% of the variability is due to therapists, then we'll see that the F value, doing this the correct way, taking into account the therapist, is much smaller than the F value that you get when you ignore therapist. And the correct test for the analysis of variance is you take your treatment mean square, but instead of dividing by the error, you divide by the expected mean square for providers. So here, this is no longer statistically significant, and the estimated proportion of variability due to therapist is reduced considerably. So it goes from 12 or 13% to 12%. Okay, excuse me for a minute. Okay, so let's look at estimates of therapist effects.
Bruce, might this be a
Yes.
good moment to pause and let people ask some questions, or do you have another
Okay,
moment?
that would be great. Yes, please.
All right, so I think earlier we had a question from Milena Karlinska-Nerebeka. I'm opening up your microphone right now. Hello?
Oh, I'm sorry, it was a mistake of technical devices. I withdraw.
Okay. So does anyone else have any questions so far? Feel free to ask if something is unclear or something that you want to ask in general. Let's just give some opportunity to do that. I don't see any questions right now.
Okay, well this would be a good time to ask because we've gone from kind of the statistical arguments to actually using those methods now to estimate therapist effects. So if there are questions about, in general, the method for doing this, would be a good time.
It looks like there are no questions, so carry on. Oh,
I'll
I'm sorry. One comes in right now. Okay, so I'm going to open up the microphone from Simri Yassin. Go ahead.
Hi, I was curious, and maybe you could go back to the previous slide. But I'm curious if you have few therapists or providers per treatment arm. So, and I guess if you let's take the extreme case where you have one provider per treatment arm, then is there anything that you can do to disentangle provider effect from treatment effect?
Well,
how does that work out? What would be a sort of adequate number of therapists per treatment in a designed to kind of get a good estimate of what is treatment and what is provider effect?
Yep. Yeah, very good question. Well, let's take the example you only have one therapist per treatment. Well, there you're pretty confounded because you don't know whether the effects of the treatment are due to the particular treatment or to the therapist who's giving it. So is it Carl Rogers giving your treatment, or is it some other therapist who you take off the street? So you really don't know whether it's the treatment or the therapist. So that's a great example. When you only have one, they're completely confounded. If you only have a few, then it's not completely confounded, but if you think about it, the results aren't very generalizable because it's this treatment given by these particular therapists. And if you go through and read the clinical trials, you'll find many of the clinical trials that get cited often as evidence for this or that have very few therapists. So I can think of several examples in which there's only 3 therapists. And again, those therapists really weren't randomly chosen to deliver the treatment. They happened to be therapists who the researcher thought would really do a great job in providing that treatment. The question about how many therapists to have is a really good one. So if you want to do a good job of estimating the variability due to therapists, you need relatively many therapists. And if you look at the power analyses of multi-level models, you really want to have, if there's a trade-off of more therapists and fewer patients per therapist, than having fewer therapists and more patients per therapist. Sometimes this is given for the argument of, well, we don't analyze therapists because we don't have many therapists in our trial, so we can't get a very good estimate of what the variability or the size of the therapist effects is. Well, that's a fallacious argument, because even more important when you only have a few therapists is that it actually may be, as we have discussed, confounding the estimate of the treatment effect.
And
So does that answer your question?
Yes, I guess so. I'm curious if there's a sort of heuristic adequate number of therapists per treatment arm that would give you a decent, sort of an acceptable level of estimation of therapists.
Well, yeah, there's a number of areas in statistics where we have rules of thumb. Almost all rules of thumb, unfortunately, are wrong. In regression, you say, well, I need 10 or 15 subjects per parameter being estimated. Well, the problem is it really depends on a number of factors. It depends on what the size of the treatment effect is. It depends on what the true intra-class correlation coefficient is, and so forth. So it's really hard to give that estimate. Some people have said, well, 10 therapists per treatment condition would be an adequate number, and that's probably at the minimal level. If possible, you really want to make good inferences about a treatment, you really should have 10 or more therapists per condition.
Mm-hmm.
Okay, thank you, Zimri. I'm going to close your microphone again because we have a couple of other questions as well. So we have a question by Joni Mihura. Go ahead. Joni, You can talk now. Hello? All right, so the question that seems like this person is not aware that the microphone is open, so I'm going to close it again. The question that this person asked was, why are treatment effects divided by therapist effects?
Well, in this where the red circle is, you take the mean square treatment divided the mean square providers. It goes back to the equations I gave for the mean square, because the only difference between the mean square treatment, the expectation for treatment, and the expectation for providers is the treatment effect. So that ratio then is going to be relatively large if there's large treatment effects. And since the provider effect is in both of those, then in a sense it cancels it out. So the ratio is only sensitive to the treatment effect. So this is a hard question to answer without having a blackboard, so I could actually show you what the mean squares are and so forth. But Kim, we didn't mention, I'd be glad to also after the webinar, if there's specific questions, to refer people to various papers or to provide the answer to. Because sometimes it gets a little technical in that way.
Yeah, so, well, that's wonderful. That's a wonderful offer. So I have a final question for now from Ingrid Erhardt. Ingrid, you can talk now.
Can you hear me?
Yes.
Oh, okay. I'm wondering how much do you think is the effect size minimized or reduced in studies which ignore therapist variables or don't look at therapist effects?
Well, that's a great question. Does this actually make a difference? And in some of the papers we've given some reanalysis of studies that shows it does make a difference considerably. And I'm going to show an example in a few minutes about where it does make a difference. It depends on the size of the therapist effects. If the size of the therapist effects is relatively small, then the effect on the error rates and the estimate of the treatment effect is going to be relatively modest. But if therapist effects are relatively large, then it's going to have a significant and important effect on error rates and effect sizes.
Okay, so this is difficult without a concrete example, I guess. So because there are many studies on efficacy, and so without having therapists considered as variables, you probably could say it's probably different than they assume.
Yes, and it's always going to be less, just by the nature of how this works. So one thing, you can't say how much less it is unless you actually know what the size of the therapist effect is. So if that's not given, or you don't have the data to determine that, then you really can't say how much it's reduced.
Okay, thank you.
Yep. Yeah,
Thank you,
question.
Ingrid. So my proposal is that we continue now with your talk.
Yes. Okay, good.
All right.
So let's go to the estimates of therapist effects. In 1991, Paul Christoph reanalyzed a number of different trials, and he concluded that overall about 8.6% of the variability in outcomes is due to the therapist. And as we'll see, 8 or 9% of the variability is a lot. It doesn't sound like much, but when you think about it, therapy versus no therapy only accounts for about 13% of the variability in outcome. So as we'll see, 8% is is quite significant. It was larger for individual variables depending on the study and so forth, and we won't talk too much about those details. Let's look at a study to see how this actually works. And here is a reanalysis of the National Institute of Mental Health Treatment for Depression Collaborative Research Program. This is the most extensive clinical trial ever conducted at the end of the 1980s, early 1990s. This was a nested design. Actually, there's 4 arms, 2 psychotherapy arms, 2 medication arms. For now, we're just going to talk about the psychotherapy arms. So it's a nested design comparing cognitive behavioral therapy and interpersonal therapy for depression. These are therapists who were selected because of their interest in and their expertise in doing the 2 treatments. They were well trained, adherence was monitored, they were supervised, and so forth. What I'm trying to emphasize here is that you would think therapist variability is not going to be very much here because you have a select group of therapists trained, monitored, and supervised. Irene Elkin said this well, and Kim, I actually have my little control panel over part of the quote here, but basically what Irene is saying is that when we study psychotherapy in clinical trials, we're studying packages of the therapy and the therapists who choose to and are chosen to administer them. So the question is, are the outcome findings applicable to the treatment, attributable to the true differences in the effectiveness of the treatment, or could they be attributable to the particular therapist who are giving the treatments? So in this reanalysis, we used a multi-level random effects model. So therapists are considered a random factor. The therapists are nested within the treatment. So some therapists gave CBT and different therapists gave IPT. We looked at the final observation controlling for the pretest at both the patient level and the therapist level. And I'll talk a little bit more about why that might be important in a few minutes. So we looked at therapist slope, both fixed and random. So when you have kind of random slopes, the estimate of the therapist effects is problematic in some ways, but solvable. So as you may be well aware, the National Institute of Mental Health spent $6 million US dollars in the 80s and 90s to do this study. And what they found is that 0% of the variability in outcome on the 4 dependent measures was due to treatment. So if you think about it, they spent $6 million to find nothing. So completely no differences on the Beck Depression Inventory, the Hamilton Rating Scale, the SCL-90, and the Global Adjustment Scale. But when we looked at therapist effects, we found somewhere between 4 and 12%, depending on whether you did the random slopes or the fixed slopes, was due to the therapist. So this is kind of amazing. So you have the best therapists you can find, train, supervise, monitor them, and so forth, and still much of the variability in outcome is due to the therapist. So I know Irene did a webinar on therapist effects recently, and I should note that when she analyzed these same data, they found smaller effects for a therapist. And I'm not going to go into the details about why that is at this point, but I think the estimates I'm presenting are accurate. So this is a clinical trial, by the way. The size of the effect here is about the same as the size of the effect that Paul Christoph noticed in his earlier study. So it's in the neighborhood, if you take the average of these figures, about 7 or 8%. What about the variance due to therapists in practice? Because you would think in practice, as opposed to clinical trials, therapists are doing all kinds of different treatments. They're not mandated to give a particular treatment. So the treatment modality given is quite different. Therapists are quite different. They're not selected particularly and trained and supervised in a particular treatment. So you'd think the variance due to the therapist in practice would be considerably larger than it is in clinical trials. Well, here's a study of many therapists, over 500, with over 6,000 patients. And again, the patients are more heterogeneous because they're not just depressed patients, but they're whatever diagnosis would come to this particular service. The outcome measure was Mike Lambert's Outcome Questionnaire 30, the abbreviated version of the typical one that's given. Interestingly, the experience of the therapist, the particular degree of the therapist, whether they were PhD level psychologists, this study done in the United States, whether they're a licensed professional counselor, a social worker, or an MD giving psychotherapy, accounted for 0%. Turns out that diagnosis as well didn't affect the therapist effects. Turns out that medication accounts for 1% of the variability in outcomes. So those patients who were concurrently receiving psychotropic medication had slightly better outcomes than those who didn't. But interestingly, it depended on the therapist. A really interesting result is that those therapists who had better outcomes generally, when their patients received medication, the medication actually worked better than it did for those therapists who had poor outcomes. Well, the percent of variability due to the therapist in practice, only 5%. It's not as great as it is in many clinical trials. So it's quite surprising because we'd expect that these therapists in practice doing all kinds of different things would be wildly different in the outcomes they achieved. But it turned out it was only 5%. Part of that is that the patients are more heterogeneous as well. So remember, what therapist effects is a ratio of the variability of therapists divide by the total variability. Well, in practice settings like this, the total variability is quite large. Interestingly, the 5% makes a very big difference. We looked at the therapists in one time period, ranked them, and then looked at the top quartile and the bottom quartile and determined their outcomes, or looked at their outcomes in the subsequent time period, so a year or two later. And it turned out that those therapists who were in the top quartile in the first time period had outcomes in some cases that were twice as large than the effects of the therapists in the bottom quartile. And in this data set, and again, remember, there's 580 therapists, some amazingly good therapists. If they got good outcomes with adults, they had good outcomes with children. If they had good outcomes with severe diagnoses, they also had better outcomes with moderate or mild distress. And then we had some therapists in this data set who were, to put it kind of bluntly, terrible. So we had some therapists in 3 years of data never helped a patient. So every single one of their patients deteriorated over the course of therapy. What I'm trying to say is 5%, where it sounds quite small, actually has a demonstrably significant effect on patients. In a recent study by Barkham and Saxon that appeared in the Journal of Consulting Clinical Psychology in England in the National Health Service shows a similar kind of effect, that a relatively small percentage of variance due to therapist results in a quite different outcome for patients seeing the best therapist vis-a-vis the poor therapist. Psychiatrist effects in psychopharmacology. This again is the other two arms in the NIMH study, imipramine, an antidepressant versus a placebo. So here it's a double blind. The psychiatrists giving the medication don't know whether they're giving the active medication or the placebo, and the patients don't know as well. 3% of the variability in outcome is due to whether you get an antidepressant or a placebo. And it turns out 3% is just about the estimate for antidepressants versus placebos, whether it's the older class like imipramine or the SSRIs. So 3%, again, sounds pretty small, but it's enough to make the production and selling of antidepressants a billion-dollar, multi-billion-dollar industry. So how much of the variability in outcome was due to the psychiatrist giving the medication? Now remember, this is double-blind studies. The psychiatrists don't know if they're giving the medication or the placebo. And it turns out 9% of the variability in outcome is due to the psychiatrist giving the treatment. And in fact, the best psychiatrists got better outcomes giving the placebo than the poor psychiatrists got giving the antidepressant. So this is kind of amazing, because in this study, the psychiatrist only saw the patient for 30 to 45 minutes every other week. And even in that time period, the manner in which they interacted with the patient had a relatively large effect on the outcome. So we had the question about, well, does this make a real difference? And here's an actual example, because this is the result for the treatment and therapist effects for the more severely depressed patients in the NIMH study with the Hamilton rating scale as the outcome measure. Now, the first row is what's reported in the journal article that reported these results. And again, remember I said that CBT, or sorry, I misspoke. The interpersonal therapy was found to be superior to cognitive behavioral therapy for the more severely distressed patients. And here we see that the F value, I don't know if you can see my pointer, but the F value is 2.94. About 6% of the variability in outcomes is due to whether you got CBT or IPT. And as reported in there, it was marginally significant, 0.09. But if you actually model the therapist effects, the F value is reduced. The P level is actually 0.22. The amount of variability attributable to the treatments is estimated to be 0. Absolutely no difference among the treatments, or between the two treatments. And in this case, the intraclass correlation coefficient was 12%. So 12% of the variability in outcome was due to the therapist. It's not statistically significant, yet it has a sizable effect on the outcome. So one of the fallacies is to say, well, I'm just going to ignore therapist effects because they're not statistically significant. Okay. Well, that is a fallacy. So you can have a non-significant therapist effect, which still dramatically influences the estimate of the treatment differences. So therapists make a difference, which leads to the question then, what are the characteristics and actions of effective therapists? So the remainder of the discussion is going to be around how we can examine the characteristics and actions of therapists when they make a difference. So Kim, this would be a good place to stop and take questions, because we're about to make a shift into the issue of how to look at and examine the actions and characteristics of effective therapists.
And we do actually have two questions. One from Zimri Yassine again. I'm going to open up your microphone right now. Go ahead.
Oh, that's me. I was curious, and I guess this is kind of fits in the transition perhaps, but what happens when you account for patient-therapist interaction effect? And how much of a shift is that liable to make in the percentage variance in outcome attributable to the patient and to the therapist independently?
Yeah, good question. So you might have an interaction effect, which is basically saying that some therapists are good with particular types of patients or with a particular patient. And so maybe it's not just simply a therapist effect and a patient effect, but there's an interaction effect. I will discuss a few, or at least one interaction effect coming up. Usually the interaction effects are quite small. We really want to believe that we're effective with some kinds of patients or with a particular type of patient. But we don't seem to see effects when we look at those interactions in research. I will mention some interaction effects, but even then they're quite small.
Thank you.
You're welcome.
All right, so the second question we have is from Annika Helga Davidson. And she doesn't have a microphone, but her question is, do you have any thoughts on the outcome achieved when therapists are working in pairs? For instance, therapist A and B work together in group 1, and therapist A also works with therapist C in group 2, and so on.
Well, that's another great question. So we've been talking about here individual therapy, each patient with one therapist. The same kind of nesting designs take place in groups when you have groups of individuals, and even there probably the effects of the nesting is more pernicious because patients within groups interact with each other. So if one patient is disruptive and sabotages the group process, it's going to affect their outcome, but it's also going to affect the outcomes of the others in the group. Now, when you get two therapists and the therapists are not the same for each of the groups, then you get kind of a hybrid design, and there are multi-level model procedures for analyzing that kind of data. But again, the issue is going to be, do you have enough data to be able to estimate the therapist separate from the other therapist you're working with? You have to have enough different combinations of therapists to make a good estimate of that. So it gets very, very complicated. But if that's the model of therapy that's being delivered, it would be really important to try to model those effects.
All right, thank you. I think those are the questions for now, so you can continue with your talk.
Okay, good. And let's see, we're about an hour into the webinar, so at the end there will be a few things I will probably skip, but I do want to get to the how do we determine what are the characteristics and actions of effective therapists. Well, what we ought to do is, if we're interested in this, we'll consult Larry Butler's chapter in the Handbook of Psychotherapy and Behavior Change on therapist variables, and Larry's conclusion at the end of the chapter was, we don't know and we don't care. So, of course, it's an academic chapter, so he doesn't say it in that way, but when he says we don't know, he really went through when he did the chapter it was about 7 or 8 years ago, and said, well, we look at all these therapist variables, we really don't know what differentiates the good therapist from the poor therapist. It doesn't seem to be their experience, their training, which treatment they give, their personality, their own mental health, and so forth. So we don't know. We don't care because he noticed that in the last 10 or 15 years before he did the research for the chapter, the number of studies examining therapist variables had actually been decreasing quite dramatically. Why is that? It's because the focus in most places has been on the treatment. We put a lot of money, millions and millions of dollars, $6 million for the NIMH study, into studying treatment differences. But and I can speak from personal experience, to get grant money to study therapist effects is almost impossible. And again, not too different than education, agriculture, and medicine. So one possibility for what makes an effective therapist is the alliance. As we have mentioned, the alliance measured early in therapy is related to outcome. So alliance makes a difference. But we don't know if it's the therapist's contribution or the patient contribution to the alliance, which is important. Okay. The therapist's contribution is what the therapist offers to the patient is what's important. So there's some therapists who are relatively good at forming alliances across a range of patients, and those are the therapists who would also have better outcomes. That's the therapist's contribution. But as therapists, we also know patients make a contribution to the alliance. Some patients come to therapy with a good attachment history, motivated to work, so they form a good relationship with us, and maybe those are the patients who are also the ones that get better. So it isn't what we do as therapists, it's what the patient brings to us. On the other hand, you'd have patients who have a relatively insecure attachment style. They may have some borderline features. Forming relationships with anybody is fraught with difficulty. So those patients are going to have a poor alliance with us as therapists, and they're probably going to have poor outcomes. So that would mean then it's the patient contribution to the alliance that makes a difference. And then, just as the previous question had indicated, it might be the interaction of the patient and the therapist. There are just some patients and therapists who get along well together, seem to click, have similar styles and so forth, and that might make a difference. So how do we determine whether it's the therapist's contribution or the patient contribution that makes a difference? Well, go through a little between and within lecture here. So when you have a number of therapists, you have within therapist regressions or correlations, and you have between therapists correlations. So here's a within therapist relationship. So if you look at therapist 1, there's a positive relationship between the characteristics and the outcome. So same for therapist 2, 3, and 4. And we're going to show this exact graph with alliance in a minute. So it might be the structure of the treatment related to outcome. So for therapist 1, when that therapist provides a more structured treatment, the results are better. But if you look at then the between therapist regression line, it's the exact opposite. So though you would reach the opposite conclusion, that those therapists who are more structured have poorer outcomes, for instance. And if you look at the total regression, you might say, well, there's no relationship between this at all. So if we're going to understand the relationship between some characteristic and outcome in therapy, we have to be careful and say, well, are we talking about the total correlation, which really is kind of an average of the within therapist correlation and the between therapist correlation. And this has a tremendous importance, and we'll look at this in terms of the alliance. So what do we know about the alliance and outcome? Well, recently Adam Horvath and colleagues did a meta-analysis, hundreds of studies, and they found a correlation of about 0.25 to 0.30. Varies a little bit depending on some moderator variables. Okay, that's a relatively moderate relationship. It's interesting because the alliance measured early in therapy has a stronger relationship with the final outcome than anything else we can measure except for the initial severity of the patient. Okay, so again, is this relationship due to the patient or the therapist? So here's a study which I'm going to try to describe how we can able to do this. So this is some counseling center consortium data. So in the United States, most colleges and universities have a mental health counseling center on campus, and this is data from a number of different counseling centers. 22 therapists, so again a relatively large number of therapists seeing 188 patients. 5% of the variance in outcome was due to therapists. Again, an estimate which is pretty similar to the estimate of outcomes in practice that I mentioned previously. So here's how we did that. Basically, this is a multi-level model. I'm not going to go again in too much detail, but if you look at the score YIJ for the post-test score for the ICE patients seen by the JAITH therapist. Okay, so that's any patient score on the outcome questionnaire 45. Adjusted for the pretest. Now here we adjust for the pretest both at a within therapist and a between therapist manner, because when we residualize post-test scores based on pretest scores, we make the assumption that the correlation between pretest and post-test is the same between therapist and within therapist, because we're using the total correlation. So here we wanted to say, well, we don't know if it's the same, so we're going to model it as both within and between. And then we have the variability Rij, which is the within therapist variability, and U is the between therapist variance. So the U 0J is the variability, the estimate of the variability among therapists. So I won't go into too much detail in this, but we did this multi-level model, and we formed the intra-class correlation coefficient for therapists as the proportion of variability due to therapists to the total variability, and that's 5%. So we call that an unconditioned model because it's not conditioned on any other variable. It's just the variability among the therapists in the final score on the outcome questionnaire, controlling for initial levels on the OQ. Okay, then we do a with and in between regression on the alliance. So in the red is the within coefficient, which is the ZIJ is the alliance score for the ith patient seeing the J therapist minus the mean for that particular therapist. So how much does the alliance vary from the average alliance for that therapist? So this kind of is sensitive to patient differences. So that patient with a good attachment history is going to be relatively high alliance with that particular therapist. Okay. Between therapist coefficient for the alliance is how much a given therapist, their average alliance, differs from the mean of all of the therapists. So a good therapist is going to have relatively higher alliance scores in general than the average therapist. Okay? So in a sense, we're getting a coefficient for the within therapist relationship between the alliance and outcome, and the between therapists difference between a particular therapist and the average therapist. And again, we're going to estimate also the remainder therapist variability. Now, if the alliance between therapists actually predicts how well therapists do in treatment, then the therapist variability should be reduced, okay, because much of that therapist variability is due to their ability to form alliances with patients. So the outcome, well, here's the coefficient. So the coefficient within therapists turns out to be non-significant and very small. So the variability within a given therapist doesn't predict the outcome. But the difference between therapists, okay, is negative, and I'm going to show a graph of this on the next slide. And that's significant at the 0.01 level. So that says that those therapists who generally form better alliances with patients also generally have better outcomes. So we're using the OQ, so lower scores are better. So that's why the coefficient is negative. Interestingly, the interclass correlation coefficient is now 0%. That means all of the variability that was due to the therapist is accounted for by the degree to which the therapist can form alliances with the patient. In other words, we've explained why some therapists are better than other therapists. Here's the picture. So the actual little data points here now are kind of fabricated, but the regression lines are indicative of what we found. So let's take therapist 3. Therapist 3 generally forms stronger alliances with his or her patients and generally has fewer symptoms, so does a better job. Okay, so not surprising, those therapists, like therapist 3, who generally form better alliances with their patients than with other patients generally have better outcomes. Okay, that's the part that is not surprising. Here's what is surprising, though, is the within therapist regression line. Remember, it was non-significant, so here we drew it as horizontal. In this case, that patient who saw therapist 3 and had a better alliance than other patients who saw therapist 3 didn't have a better outcome. Okay, so that's a little more difficult to kind of understand. Let's take also a patient who had a relatively poor alliance with therapist 3. Remember now, therapist 3 is pretty good at forming alliances, in fact better than the other therapists. Nevertheless, this patient had a hard time forming an alliance with therapist 3. Let's take as an example, this patient has some borderline features, has a hard time forming relationships with anybody, insecure about the relationship, fearful of losing that connection, yet sabotaging it at the same time. So that patient has a relatively poor alliance with therapist 3 compared to the other patients. However, had that patient seen therapist 2 or therapist 1, they would have had even poorer alliances. So perhaps for that patient, seeing therapist 3 provided a better relationship with somebody than that patient is used to with almost anybody else. So therapist 3 was able to offer something to this patient which was therapeutic, even though it was difficult for the patient to form a relationship with that particular therapist. Okay, so Kim, I'm going to actually stop here because the next example takes this on a little different tact, and I don't think it's central to the explanation. So what I wanted to illustrate by this particular study was how to disentangle the within therapist and the between therapist relationship here on the alliance, but also with any characteristic. Same thing would apply with empathy, for instance. We know empathy is correlated with outcome, but is it the therapist offered conditions of empathy that makes a difference, or does it have to do with the patient? Because some patients make therapists look really good. So they're agreeable, they're not challenging, they're not resistant. So in that case, the therapist is going to look more empathic. So what we need to do in process research is really disentangle the between therapists and the within therapist effects for these kinds of relationships. So this is another good time. Let's take some final questions, and then maybe somewhere during the questions I'll just summarize with a final slide.
All right, so let's see if we have some questions here. I don't have any raised hands at the moment, but usually it takes a little while for people to... Yes, there is the first hand. Justin Smith, go ahead.
Bruce, I had a question about where what kind of measures of fidelity would come in with therapist competence and also just adherence to a particular treatment and how that plays into the therapist effects.
Kim, I'm having a really difficult time hearing the question.
Yes, so do I, and I get comments from the public that they do too. Justin, would you mind typing in your question or speaking closer to your microphone?
Happy to type.
All right, I think I can hear you now, so if you speak closer to your microphone, that might work.
Sure. So my question, Bruce, is how you would kind of put fidelity into the therapist effects, and where you see that fitting, especially, obviously competence and adherence, but just kind of a general idea that some therapists are better at implementing a model or delivering a particular treatment.
Right, good question. And I'm going to repeat it because I don't know. Still, the volume was quite muted. The question is, how does fidelity or adherence play into this? Because some therapists are better at implementing a particular model than other therapists. Well, there's been now 2 studies, one by Zach Immel
Unmuted.
And another by Paul Christoph and
Muted.
looking at adherence. And it turns out that adherence ratings of therapists have a very large patient component. So you really can't just say therapist 3, for instance, is quite good at implementing a model, because there's quite a bit of variability in that implementation depending on who the patient is. So if the patient, let's take cognitive behavioral therapy, is quite good at doing the homework and is motivated, follows all the instructions and so forth, then the therapist's ratings for adherence are going to be really high, even though much of that is due to how cooperative the patient is. Contrast that with a patient who's quite resistant, doesn't do the homework, okay, doesn't do the thought listing, the reality experiments and so forth. Well, there the therapist is going to have a hard time looking adherent because the patient is not being cooperative. So it might turn out when we actually disentangle adherence that what makes a difference for adherence is the within therapist adherence is related to outcome rather than the between therapist adherence. By the way, we know from Webb and DeRubis meta-analysis that in general, adherence to a treatment protocol is unrelated to outcome. But it might be within therapists in that those patients who follow the protocol of a given therapist, in other words, are more on board with this particular treatment, might have better outcomes. So interesting question, because we're trying to find data where we can do the same disentangling analysis with adherence ratings. So if anybody listening has a data set like that and wants to collaborate, we would really be eager to do that. So really great question.
All right, thank you. So we have also a question from Simri Yassim again, and let me see if I can find his microphone. Go ahead.
Hi, so sorry to ask so many questions. So these results, I understand, are based on analysis of working alliance inventory. And I'm curious, have they been replicated in other measures of alliance, such as observer rating of alliance, or I'm not really aware of what the range of measures are for alliance besides WA.
Yeah, good question. So in this particular study, this is the patient-rated working alliance inventory. So the question is, if you had the therapist-rated alliance score or the observer, would the relationship be similar? This is a rather interesting result. And when we first did it, we really didn't know if it's going to replicate or not. Since that time, there have been 2 or 3 different replications. And I'm trying to think whether they were patient-rated alliance or not. and I can't recall. I don't think it's going to make much of a difference because the patient-rated and the therapist-rated alliance and the observer-rated alliance are pretty highly correlated. But it's a question worth examining. We did, and actually what I was going to show you in the next few slides is we did a meta-analysis in which we replicated these results as well. And in that database, a number of the studies are patient-rated or observer-rated. So increasingly, I'm more confident this is a result that's going to be replicated. By the way, Kim, as a question, I know you put the recording of the webinar up on the web. I would be happy to provide the slides as well. I don't know if you have those available to the participants, but be glad to send those.
All right. Usually we don't have them there, but yeah, sure.
Yeah,
I have
think
to.
it'd be helpful. Yeah.
Yeah, I have to ask
Okay.
Sven if it's possible. I have a question from Michelle Leitman, who is without microphone, and she asks, do you have any thoughts about how we would start looking at the specifics of what makes these good therapists so good?
Well, Michelle, great question. You know, this is just a beginning to start to disentangle some of the relationship we know are there. What we really need to do is to be able to identify, perhaps outside of therapy, what are the characteristics and actions of effective therapists. The only study I know of this is a study done by Tim Anderson where he actually gave a test to therapists outside of therapy. And the test was kind of a behavioral test. He gave them a vignette of a very difficult patient and had the therapist, so that was a stimulus that was the same for all therapists, and had the therapist respond to that stimulus. And he could rate the facilitative interpersonal skills of the therapist. And actually that accounted for the outcomes achieved by those therapists. Part of the problem in trying to identify the characteristics and actions of effective therapists is if we look at tapes of therapists, much of what we're seeing in terms of good therapy is due to the patient. Again, the patients who are motivated, cooperative, and have good attachment histories make therapists look good. So we can say, here's the successful case, and we look and see what the therapist did, but the patient has a contribution to that process as well. And that's why we need to kind of be able to disentangle that relationship in a way to be able to identify what makes some therapists better than others.
Yes, I know of that study. It's very interesting. The Anderson study, I like it a lot.
Yeah, yeah. It should be mandatory reading for everybody interested in this topic because it's the first time and only time, as far as I know, that someone has been able to look at characteristics of a therapist outside of therapy. One of the difficulties is to be able to find data in which have access to therapists. So most of the data I've dealt with, the therapists are de-identified. So we don't know who they are. But therapists are kind of reluctant to be studied in this way. Sorry.
Well, in general, I think I've been giving personality questionnaires to therapists to identify whether this influences their effectiveness, and you know, we've been having very angry reactions from them, like, you know, they're sort of responding like, you are treating me as a patient.
Right, as a subject.
No,
yeah. I know.
So I think we're through with the questions. So if anyone has another question, please ask. Raise your hand so I can open your microphone. Let's give them 1 minute. And otherwise we're already at the time that we should stop. So let me see if there are any final questions. Yes, there is. Okay, so here is the question. Santiago. Juan Santiago, go ahead.
Hello, are you listening to me okay?
Hello? Yes?
Okay. Dr. Wampold, thank you very much. It's been an honor listening to you. My question is the following. What implications for treatment training, for therapist training, do you think they are of this kind of studies? What should we tell therapists to do, not to do, to advise, not to advise? How could you include some of this information in the training programs of psychotherapy?
Yeah. Well, it's a great question because I think, you know, we want to know what are the actions and characteristics of effective therapists. We really want to be able to take what we learn there and say what are the implications for training therapists. Okay, and you know, I'm sorry to say we just don't know enough about the characteristics and actions of effective therapists to have definitive conclusions about what we should do in training therapists. I mean, the implications of the study I talked about here is that we might measure the average alliance of therapists and identify the degree to which therapists can form alliances. But you know, even with the alliance, even though it's a really good process measure, we don't really know what therapists do in the session to create better alliances than other patients. So here, you know, it's just the patient's rating of what the alliance is. We don't know what therapist 3 did to create that better alliance. And we're colleagues and I are trying to do some research to look at what is the therapist's actions that actually create the alliance. And you could look at some of the people who talk about alliance, like Miran and you know, I'm kind of blocking on the others, but to look at that. But again,
Saffron, I think you meant.
we need better research on what good therapists do before we can actually say what the implications are for training.
Mm-hmm. Thank you very much.
Yeah.
Thank you, Juan. So I think it's time to wrap up. Thank you so much for this very interesting talk. And I want to say to everybody who's attending, thank you for listening. And I also would like to announce that our next webinar is going to be another dissertation dissemination webinar, and it's going to be by Ingrid Erhardt, who is also now in the audience. And this will be the end of February. We'll announce it later this week. So please attend that one too. And also we will have in March a webinar, another Distinguished Researchers webinar by Paulo Machado. So now you know what's coming up. We hope that you're coming back to listen to more of the webinars that we organize. And I see that a lot of people are posting here some kind of virtual applause for you, Bruce. So
Oh, good. Thank you. Kim, I should say thank you to you and to the others on the facilitation of the webinar. It's I feel a little intimidated doing it. I can't see the audience, but you've made it so easy to do. Just wonderful. And thank the audience for being part of this, and great experience. So thanks all around.
great, thank you. All right, so we're going to end this webinar right now. Thanks everybody and have a good day or night, whatever time zone you're in. Bye-bye.